Great to have you here, Juan. Um, uh, this is Eapen Thampy with Psychedelic, Missouri. I think this is going to be your first recorded interview, but I've got Juan Hernandez here from down in southwestern Missouri. Juan, you want to kind of give us your background real quick, and we'll start talking about your pathway and interest in psychedelics after that.
Hey, no, I appreciate the opportunity to connect with you, Eapen. I'm 53. We live in Table Rock Lake, Missouri. My wife Julie and I spent quite a bit of time in California. I have a graduate degree in clinical psychology and am a licensed therapist in the state of California. But around 10 years ago, my wife and I started a detox addiction and alcoholic detox program in Southern California. And we maintained that operation for several years. But about 7 years ago, we relocated to here in the Midwest, and we started EagleCrest Recovery, which is located in Bentonville, Arkansas. And EagleCrest is about 6 years running now. We're the #1 rated program in the state of Arkansas, highly regarded in the Midwest. We have a 45-bed program spread around 3 campuses with an extensive outpatient program as well. And so we focus on SUD, and my interest is seeing where psychedelics could really make an impact with the recovery rates and the relapse rates that we see in our industry.
Yeah, and so you just got back from Switzerland.
Correct. Yes.
Tell us about that.
Well, I'm in the California Institute of Integral Studies program for psychedelic therapy certification. And my academic advisor within that program is actually a doctor. He's German, but he is located in Basel, Switzerland, at the University of Basel Hospital. And he is a palliative care physician that is also doing research on LSD and psilocybin with terminally ill patients and palliative care patients. And he had recommended, I struggle with a disorder called cluster headache syndrome. It's a rare neurological disorder. And I had mentioned that to him in passing, and he had shared with me that there is a similar research program at the same hospital doing LSD treatment, clinical phase 1 double-blind study for LSD for cluster headaches. And it was the only study going on in the world at the time. So I was able to get screened and eventually get approved, and went out to Switzerland on first week of January, and spent almost a month there. The University of Basel Hospital has been there since, I believe, 1490, and it is one of the epicenters of LSD research, I believe, in the world. LSD was discovered in Basel in 1930 by Dr. Hoffman. And so that unit there has just been on the cutting edge. And it was great to meet the clinical staff. It was 100 microdose once a week for the first 3 weeks. And that was a wonderful experience. As far as the cluster headaches, time will tell if it's a benefit, but I did see some other benefits from the LSD experience after a month and after some time being back. So Switzerland was a great place, and I go back actually June 1st for the second part of the clinical 1 phase trial that they have there.
So was this actually LSD, or is this some proprietary version?
No, it was LSD. Basel has 2 or 3 major pharmaceutical companies located there. I believe Rausch is one of them, and I believe that one of those pharmaceutical companies is working with the research team, and they provide the vials, but it was pure LSD. Wow. There is an I believe there is a doctor in Hanover, Germany, University of Hanover, that's also doing another cluster headache study with LSD, but they're actually looking to tweak it a little bit to market it under a different name. I don't know if it's similar to MM120, I believe, or something like that. But no, it was pure liquid LSD.
Yeah. How far along are these trials? How close to approval in Switzerland or Germany or Europe?
That's pretty interesting. I was able to, because I'm actually a licensed therapist as one of the participants. So the research staff actually interacted with me a lot more than I think the average participant. I was able to actually meet the director and the founder of the research program. Mm-hmm. And so basically their outlook is right now they're in clinical 1 trials, and that trial will run until December of this year. And then they're going to submit their results based on the 30 participants that were in the clinical 1 phase trial. So there's still some time out. I was able to get their feedback on their opinion in Switzerland on the legalization of these substances. They believe that after the FDA ruling that MDMA, for example, is going to take a back seat, and it pushed it back to around 5 to 7 years. Mm-hmm. They believe that LSD and psilocybin has now come back up to the forefront, and they're looking at 2 to 3 years. They believe it'll be legalized. I think they were mentioning that for Switzerland, but I think they also felt that for the United States. I did ask them about ketamine. They had a little bit more of a pessimistic view of ketamine. Their take is that it could be temporarily helpful, but long-term observation, long-term scans and follow-up is not showing any neuroplasticity activity or any increase in brain matter and neuronic activity as compared to LSD and psilocybin. That's their take on ketamine, even though they believe it'll still be around for quite some time. But they feel that psilocybin and LSD has a lot more to offer than just standardized ketamine treatments. So,
so you have, serotonergic effects and neurovasoconstriction from some of these tryptamines. I've heard anecdotally that psilocybin also has a lot of utility for cluster headaches. We have been talking to Cluster Busters, mm-hmm. which is a nonprofit advocating. But I mean, this is a condition with like severe, like when you have one of these cluster headaches, it's like knocks you out.
Yeah, it's hard to describe. It's horribly debilitating. There's 2 phases to it. When an attack is going to come on, it's almost like you've got like a flu in your head. You start feeling there's a ringing in the ears. You start feeling pressure, like your head's in a vice. It's almost like the engine's starting up to hit you, and there's kind of a dark feeling to it. It's almost like an instant depression that's coming on, and then within a few minutes the attack will hit, and that can last anywhere from 15 to 45 minutes. Depending on the pain level, it's extremely excruciating. I mean, I literally have to isolate myself in a dark room, try to keep people away, because I end up sometimes, there's, I don't want to say seizure activity, but there's rolling around, there's screaming, there's, making noises. I mean, the pain can be it's like a torture. It's like listening to a torture chamber. And it's the worst experience that you'll ever have in your life. But when it's over, it's like the best day in your life. I mean, they literally end within a minute, and it's just like you got a new lease on life. And so part of the process is psychological, of like, okay, when is this going to hit again? And then if you think it's going to hit, and if you're in a social setting or out in public, it could get a little tricky, because, I usually carry the oxygen tanks with me. I believe that the microdosing did have a positive effect in keeping the attacks away and keeping them minimized. But it appears that I have to microdose, I think, every 2 or 3 months to keep that going. Now, for the purposes of the research project in Switzerland, I also learned how difficult and how much work that staff have to put into conducting a research project appropriately. So I feel like I have an obligation to that team to follow the rules. So they asked me when I come back to the US, do not do anything. Don't do any microdosing. Don't do any psilocybin unless you absolutely have to, if the attacks get really bad, because they're still trying to track the study, and I don't want to pollute any of the process. Even when I go back in June and it's a double-blind placebo 3 weeks, it's still, I want to honor the commitment and make sure that we finish at least this participant's file, because I think they deserve that. And so I'm trying to hold off on that, but I might end up having to microdose a little bit before I go back. And as long as I report it, that's okay. But I'm trying to keep the integrity as much as possible. So I think there is a maintenance involved, but it's pretty, it could be pretty spread out, if that makes any sense at all.
Yeah. So like, describe like the actual treatment protocol that you experienced.
So it was funny, Eapen. I'm the only American that's participating in the study. They have interviewed several other potential patients from the United States that actually qualified and got through all the screening process, but they just never show up. They would never make it actually to Switzerland. And so I showed up on a Monday morning at 8 o'clock. I was able to find the campus. And I remember I found the right building and I walked in and they were shocked that I actually showed up. They were like, oh my God, the American's here. Like they were shocked that I actually took all the time and the effort to fly all the way over and spend time there. So that was really, really interesting. The building that I was in is historic. Gosh, they've been doing research in this building for 50 years. So I believe the room I was spending time in, Carl Jung had been in that room, Friedrich Nietzsche had been in that room. It was pretty cool. You show up and you are given a piece of bread and water just to put something in your stomach. That is a choice that you have, but that's the only thing that you're allowed to eat. We start at 8 a.m. They will do a blood pressure check. Your blood pressure's got to be under 160 for them to actually give you the dose. And that was funny because my blood pressure was like coming in at 158. So I was lucky that I was able to meet under the threshold. So they check your blood pressure. They will do a drug screen to make sure there's no other substances in your body. They do allow for, if you're have a medical purpose for THC, they do allow that and for you to participate in the study, but you can't really have anything else in your system. They request that you don't drink alcohol for 24 hours prior to the dosage day. And again, they start, and the screening process when I arrived, actually, the day before I started, I had to do an interview with a psychiatrist on site. So we did the Beck's depression inventory, did a couple other inventories, interviews, so forth and so on, just to make sure that there's no underlying psychological issues. And then when they're ready that morning of the dosing, I'm in a hospital bed. I got my shoes off. They asked me, do I need anything else? Do I need water? I can bring my laptop. And then they give me the dose. And they don't tell you if it's a placebo or not, but within about 25 minutes, you know that it's not a placebo. I'm in that room for 10 hours. There's always somebody in that room with me. And they had a therapist, and then they also had a PhD psychologist. One was Swiss, one was German. So both of them would be in there with me, or sometimes they would rotate if one wanted to go have lunch, so forth. They give you lunch as well, but they're doing my blood pressure every 30 minutes throughout the day. Mm-hmm. And I have to do a questionnaire every 30 minutes throughout the process, which can be a little bit of challenge because of the visual difficulty you can have under the influence of trying to mark the sheet on how I'm feeling and what the effects are and so forth. And then at the end of the day, you got to do another questionnaire with about 250 questions. And that's when the dosage is receding. That's usually around, I'd say, about 5 p.m., 5:30. The effects should be over. And the questionnaires that they're doing, part of it is to make sure that you're back down to baseline if the effects are over before they let you go home. And I'm not allowed to smoke cigarettes during the day while I'm there as well. But it was great because I got to hang out with these clinicians. We got to talk shop. We got to know each other really well. The personal experience was, as you could tell, I like to talk. So I was kind of all over the place, just chatting away and talking about different things with these gentlemen. And didn't have a lot of hallucinage. When I went to the restroom, some of the walls were a little shaky, but I was able to, I always knew where I was and I was able to be consciously aware. But it does kind of keep you awake for some time. So that was every Monday for 3 weeks. And then the rest of the week I'd have off there in Switzerland. So
is this trial, is it just, they dose you and monitor the effects and take data on your headaches and whether or not they're happening? Or do they also do any kind of like therapy adjunct?
There's no therapy adjunct, but one thing I failed to mention was when I first started interviewing to be a participant, they said that if you're on an SSRI, Lexapro in my case, that I had to be off of it for 60 days prior to the trial, which I was able to accomplish. And then when they accepted me into the program, they had me do a daily log that I continue to do for measuring the cluster headaches, and it's broken down into severity, what the symptoms were, what time it was, how long it lasted, what I think the triggers were, and how I treated it. And it's always oxygen at 15 psi. So I started maintaining a log in November, December. I send those at the end of the month, every month to them. I was there in January, but I still maintained a log while I was there. And then I'm continuing to maintain those logs. So at the end of every month, I submit that to them via email for them to keep on record. So I'm constantly logging the attacks that come every day if they come. And that's pretty much it. They are strictly looking to see if the symptoms reduce or if they get eliminated, or obviously if they stay the same or get worse, because there's no guarantee.
Yeah. Well, that's so you said they're in stage 1 of their clinical trial?
Correct. They're working with the Swiss government. I believe that per each participant, this is about $100,000 that of cost for each participant in the study, and the Swiss government actually pays for that to work with the University of Basel Hospital.
How many subjects are in phase 1?
30. There's 30 slots. They didn't tell me. I know that they haven't filled all the 30. The problem is they need to get to 25 or 30 in order for it to be validated, in order to proceed on a clinical phase 2. And so they're still trying to get a few more participants into the study to finish by December of this year. They might be able to get an extension, but I don't know. And I really hope they do, because again, this team put in a lot of work every day to make this happen. A lot of work.
And then phase 2 is a larger population.
I believe it could be. I know that phase 3 is the largest population out of any study. I've learned a lot about research since I've been participating, but correct. But they would still have to publish in 26 and then try to seek funding for a clinical phase 2 if it gets approved, which would be 27, 28.
Right. So this could take 6 to 8 years to come to completion.
Yes, I believe so. What the director of the research project, she told me 2 to 3 years, but I think she was just meaning more on a global scale of how it would be approved and descheduled. I don't know if she was talking specifically about Switzerland, or if what they were saying is that if we're going to develop a medication for cluster headaches using LSD, that's what these clinical phase trials are for. So I think in regards to cluster headache medication, that's what's going to take a long time. As far as psilocybin being descheduled and so forth, I think for general application or mental health application, I think it'll be a lot sooner. I think that's what they were saying. And I get to go back in June, and when I go back in June, I will meet with her again, and it would be great. I could take back some questions with me and get some answers from them directly. And another great thing about it is that while I was in Switzerland, I was able to actually personally hang out with my academic advisor from CIIS. We were able to meet in person. And these clinical researchers definitely want to stay in touch once I am finished being a participant, because we do have some clinical boundaries as far as social interaction at this point. But when I finish the trial in June, but I still have to go back in October for a third time, just for one day, to do the final physical for them to close out my file, which I'm going to do. I'll probably go out there for like 5 days. So, but I'm going to continue these relationships with these researchers and these folks that I met at the University of Basel, because they're really wonderful people. They're very focused, and they're very secularized on how they're approaching this. They're definitely on the medical model. I will say that.
Yeah. So does this, like, if you do a clinical trial, like a phase 1 in Switzerland, how does the US FDA look at that research?
That's a good question. I'd have to maybe I can ask them. I'd have to find out. I don't know. I'm sure that individuals at the FDA might see what's going on in other countries, depending on what specific research they're doing or what area they're involved with. But that's a good question. I should definitely check that out. And the Swiss government is very thorough, and they do have a lot of stringent. But I have a feeling that in Switzerland or in Europe, things can move a little bit faster for approval versus the system at the FDA. But that's just a layman's understanding of it from this point. They do it in a hospital. A lot of people will say in the community that, gosh, the medical model, and it's a very sterile environment. I got to be honest with you. When I was sitting in that hospital room for 10 hours, I was fine. The dynamics of the personalities of the clinical staff and was really what made a big difference, I think, in the experience. And you do need emergency services located close by. If I happen to have a cardiac arrest in the middle of it, they need an ER close by to get you into just in case. And I think that's one of the requirements, is that a hospital setting is really good for research because you have any emergency services that you might need right there for the participants, just in case there's something going on. So
Right.
So I think that's actually a requirement just for safety reasons. But they're building a brand new building in the next couple of years for this research team, so that'll be interesting as well.
Did you have did anyone, if anyone has had an adverse event during this experience?
No, no adverse effects. I believe that they were a little surprised that after me not having a lot of experience with LSD personally, that I responded so calmly, or I was just able to carry on conversations throughout the day. I mean, I felt it was an enjoyable experience, but I could tell they're very good about boundaries and ethics and so forth. But I could tell in some of the conversation that, yeah, they've had some patients that have had, I think, more emotional responses, but nothing abnormal, nothing that you wouldn't expect in an experience like that. No emergencies or anything like that. So I haven't heard anything like that of any bad experiences or adverse effects with anybody there. And there certainly wasn't any while I was present at the hospital at all. So it was actually a pretty calm and well-run operation.
Right on.
They're also working on another project. I don't know if you've heard about this, but talking about LSD treatment for mental health, you're still looking at a very expensive treatment modality. So one of the concerns for everybody is trying to eventually make this affordable for the general population. So instead of somebody being under the influence of LSD for 8 to 10 hours and have to be monitored for that time, they are looking at minimizing that to 4 hours. And how they do it is administering a blocker. And so down the hall, there was another research program, I think clinical phase 1, where they're trying to work on a blocker, which means they give you 100 LSD, and then after 2 hours, they give you the blocker, which is supposed to completely block it after 2 more hours. So instead of 8 to 9 hours, you've got a 4-hour block, which is a much more affordable delivery model. Because they're trying to research if that block actually happens. And number 2, what are the results of the LSD being in the system active for half the time? And if it's the same results as 8 or 9 hours, then it'll put some validity into that blocker and make this process more affordable for people down the road, if that makes sense. So they were also working on that as well. I forgot the name that they had about that.
Yeah. So I guess you'll be so you're going back in June, you said. So I guess you'll miss the Psychedelic Science Conference in Denver.
Yes, I was going to go to that, but I'm obligated to go. And I'll just tell you, being in Basel and again being connected with these folks is probably the best conference I could go to when it comes to psychedelics. But I am bummed out that I can't make Denver. I really wish I was able to go there. I forgot which dates it was again. Do you know off the top of your head when that is? Is it in the middle of June?
I think it's like June 17th through the 23rd, but
Yeah,
I
that's
think that's about right.
but I'll definitely hit the next one after that. There's another conference in, I believe, in Coronado in San Diego coming up, and I don't know if it's in the summer. That's more pharmaceutical when it comes to psychedelics, where the research is, where the development is. But that's another conference that I was considering going to. It's just quite a distance from Missouri.
Yeah.
But I'll definitely send you a link on that one as well. But as far as, Eapen, the big reason I got into this is that, working in addiction and alcohol, substance use disorder, our relapse rates overall in the United States are pretty poor. You're looking at, basically an 80-85% relapse rate. I think that's pretty positive as far as, some people would say 90% failure rate. I'd say about 85%. So that means at least 85% of these people are relapsing at least one time, if not more, throughout their recovery journey. And yeah, I think one of the toughest parts is that, especially with some of the harder cases that we deal with, we're talking about patients that have been on methamphetamine for 20 years, 10, 15, 20 years on daily usage, 20 years of daily alcohol use, or opiates, but especially methamphetamine, how it physically deteriorates the brain and really causes physical damage, that, antidepressants or other medications and counseling, I don't believe can be maximized and truly effective. And that's just been a reality that we've had to deal with. And we're hoping that, and we have a lot of hope that psychedelics will actually rewire and increase neuroplasticity and heal the brain physically, which will enable them to absorb more therapeutic process and really move forward and get out of the psychotic episodes that some of these folks experience. Otherwise, they're going to keep relapsing, and they're going to be back into the system repeatedly. And so, again, what the brain goes through addiction and alcoholism is just incredibly destructive, and we just haven't had anything that can actually heal the brain physically as much as we've seen in the research. And that's what we're hoping, that eventually psychedelics can really start making an impact in relapse rates, because we're trying to work ourselves out of a job, basically. And we do want to see those rates go down. If we can get them down to 70%, that would just be an incredible victory. And it would save millions, if not billions of dollars nationwide. It was interesting that recently Arkansas, somebody introduced a bill to try to eliminate mental health and addiction out of insurance coverage. That suggestion didn't last very long, but a lot of us had to take a hard look at that really quick. Woke up to that news article, and I basically did a little bit of research. And you stop addiction treatment services, and you're going to see an increase in ER visits, vehicle crashes, domestic disputes, prison population. So many things go up if we're not holding back the tide. Again, the relapse rates are pretty poor, but I believe that the addiction healthcare system is really working to hold the tide back. And I think that wouldn't be as noticeable as if we didn't exist. I think people would really notice how bad the situation really is. So we're really holding back the tide waters, and that bill was canceled pretty quickly, thank God. But it just really kind of made us look at how much I believe we make a positive impact on a lot of services and within the state. So again, I believe that psychedelics can really make an impact on so many levels, not for the lives of the people that are struggling with SUD and their families, but also for the community as a whole, because I believe it'll lower healthcare costs over time, because going to treatment is actually pretty costly.
Yes.
That's our big hope. We just haven't seen anything that these medications could possibly deliver. So really hopeful.
So I'm sure you have seen or heard of the potential for any of these psychedelic therapies to be effective, kind of curious, like, what your anecdotal experience has been in terms of, like, who are you hearing this from? What's been their experience, as much as you can share any of that.
What do you mean? What do you mean? And what do you mean by that? If you don't mind.
I mean, like, you come across people who come to your recovery services and say, this has helped me in the past, or
I mean, when it comes to treatment worldwide, and I think we all use basically the same playbook. I mean, there's not a treatment center that's discovered some secret magic way to lower relapse rates. I mean, we all use, CBT, DBT. I mean, we all use the same psychological playbook. I think that the big difference could be the quality of staff that you have. But with that being said, most of the patients that come in are pretty much just following the protocol that we give them. They're pretty focused on their own personal journey and the issues they're going through. Everybody's usually very hopeful and optimistic, and for the most part, they trust what we have to offer. But basically, what we do is, you have the detox portion, which is highly medical. We're getting them physically stable in order to continue treatment. We're getting them through withdrawal symptoms and the dangers that could pose. And after about 5 days, when their tapers and their medications are over, they're discharged into residential treatment, which is psychological. And they have 6 hours of group therapy every day, individual therapy session every week, plus other activities. And so, and they're heavily involved with that. I think maybe the best way to answer your question is, what do us as a staff observe ourselves, silently, or amongst ourselves? I'll be honest with you, I see people discharge, they discharge successfully, and I can tell you that, the chances are that person's going to be back within 6 months. You can just tell. And it's not because the person doesn't want to, it's their motivation. It's because the damage that they sustained is too great for 30 days to take care of. The ideal model for treatment, Eapen, is, the 30 days is just a start to stabilize. The ideal model is for people to continue with support groups, but individual therapy and outpatient and group therapy for at least a year or two after discharge to really work out underlying issues. For example, I would say 75% of our patients are diagnosed with PTSD. PTSD is a big driver for addiction and alcoholism underneath. That's why I was pretty bummed out about the FDA rejecting MDMA, because MDMA has an amazing ability to deal with PTSD. The biggest theme with that is trust. When people have PTSD, they don't trust anybody or anything, and that creates intense anxiety. Even our own medical psychiatrists have said, wow, I should have studied PTSD instead of addiction science, because I would, that's almost more applicable to our clients. So unless they have the opportunity to really work on these things after discharge, usually these problems persist. And your average person cannot take time off to go to rehab and then stop and pay a therapist $150 a week for the next 2 years. It can be financially heavy. They might not have the circumstances, stability, or whatever. So that's where we see is the aftercare is the part that is very most crucial. And we feel that's the part that's lacking. That's another reason that brings us back to psychedelics, is that there's something about psychedelics that does some sort of a positive permanent plant. I mean, okay, you might have to maintain it periodically, but there's something that psychedelics does that creates some stability in the psyche of the patients that just pushes them ahead so much right off the bat. I don't think therapy and antidepressants could accomplish that under 2 years, let alone or ever, if that's making any sense. And when somebody has a foundational, some sort of a stable platform in their psyche to start really self-reflecting and working on things and growing forward, that's a huge key. And psychedelics can do that, I think, very effectively. It can be done very affordably, and it just again does a lot of work in the brain on its own. And it, like I said, it creates a stable platform for people to start growing and working on their issues and moving forward, and not having to repeat these things anymore. And because we always tell them we love our clients, but we don't ever want to see them again unless they're visiting. So that's a little bit of a ramble, but hopefully that might give you a little bit more insight.
Yeah. The
biggest challenge that we have, though, just to mention, with a certain percentage of our cases that are really hardcore cases as far as their usage and their time, is that the cardio issues that they develop. We have patients that come in that are diabetic that haven't been to a doctor in 3 years, or they've got cardio issues and they haven't seen a doctor in 3 years. So that's part of what we do in detox, is we try to address those issues as best we can in the limited amount of time that we have. Dental issues, abscesses. So the issue about cardio is the population that probably will benefit the most are the ones that are higher risk at cardio issues that might prevent them from getting the treatment in the first place. You know, when we look at a delivery model down the road, they're going to have to pass a cardio screening. And that's like the number one issue that they have, is cardio issues based on their usage. So something's going to have to be worked in there, hopefully, for these people to get that help. Maybe it's an additional medication for their heart symptoms initially or whatever, but that's the biggest challenge we have, is cardio condition preventing them from receiving the treatment.
Gotcha. And what's the parameters there? Do you, like, if you have a patient with those cardio issues, can you mitigate that? Do they get screened out of the protocol?
As far as for recovery itself, no. We just, we a lot of them, we're used to dealing with that, and so they do get medications during the detox phase to handle any cardio issues. If it's super severe, we'll transfer them to a hospital, or they might not just be ready for treatment. But I think 99% of the cases we're able to manage and get their hearts to a better condition within 5 days and get those symptoms kind of alleviated, because remember, the withdrawal symptoms raises your cardio activity. Your body, basically what happens with, in layman's terms, with withdrawal, is that when you stop using, all of a sudden your body tries to recalibrate, but it tries to do it too quickly and too hard, too fast. That's when you can have a heart attack. That's when you can have seizures. What we actually have to do is slow that process down during the detox phase, so it doesn't do it too hard, too quick, because the body wants to rejuvenate really fast, but it can do it so hard that it could create medical issues of itself. So part of our job is to ease that process to the taper, is what we do, because during that recalibration, the heart starts working again. Like, okay, we're gonna go back up the hill, and that's where the complexity comes in. I was terrible at math and science as a kid. That's why I never went to medical school. I trust our medical team. They're the ones that handle that, and they do a really, really good job of that. So, but that's the best way I think I understand it.
Yep. Fair enough. So, like, kind of like looking forward, when a therapy like this, like MDMA or LSD or psilocybin, is approved, how are you looking to integrate that into your recovery services?
That's a good question, and I think we're still trying to determine what that looks like over time. My initial idea is, we obviously have our program. Rehab is split into 4 different units. You have detox, you have RTC, which is residential treatment, which is inpatient. Then you have PHP, partial hospitalization, and then outpatient. And those are your 4 levels. I would recommend, obviously, 30 days of treatment, and then possibly a month or 2 of outpatient services. And then they're done. And then let's say we just kind of draw a line there. And then let's look at psychedelic application from there on forward. There'd have to be some pre-prep through individual therapy, establishing goals. There'd have to be a medical screening to determine if their hearts are in a condition to within an acceptable range, blood pressure, whatever it might be, in order to partake in that, in a dosage. And if somebody, for example, has too high blood pressure, that doesn't mean they can't do it at some point. They just might continue to work on their blood pressure, maybe get a medication from their doctor until it's within a certain range that they can partake in the study. But we definitely want to have them pre-screen for any psychiatric issues. We want to have them pre-screened as far as any cardio issues. And then we want to have an established therapeutic process, which really establishes objectives and goals prior to dosing, and then follow up after care. Again, that's pretty generalized on how I'm explaining it, but there would definitely be some time from residential discharge to actual dosing. I'm assuming maybe 2 to 3 months, depending on the individual case. Somebody might take 6 months before they can pass the cardio and partake in the study. What the actual dosing would look like, I think, is pretty common. I don't know if it would be a day site. I don't know if it would be a residential site. To make it more affordable, I'm assuming that it would have to be a day site like we see in ketamine clinics, where they would come and get their dose, and then, you know, when they were ready to leave, they were driven home, and kind of like the same process I go through the research in Switzerland, where you're doing questionnaire and they're making sure that you're back down to baseline before discharge and so forth. And then I actually, and the biggest thing I think is follow-up monitoring, you know, what that would look like. Because I believe you'll need at least 12 to 18 months, if not longer, to follow up on clients to see how they're doing, to see how this is taking effect, self-reporting, whatever it might be, if they've relapsed or not. That's where we're really going to see where the work is done. And that would be a completely different phase that would have to be recorded. I don't know if we use some automation or electronics to help monitor, to make it really easy. But definitely, and that's the challenging part about patients in substance use disorder, is unfortunately substance use disorder leads to chaotic lifestyle, instability, financial issues. So sometimes it can be hard to stay in touch with participants after they've discharged. You know, they switch cell phones, or they lose their phone, or they get a new number, or they move around a lot. So it's kind of, sometimes it can be hard to track them, to stay in touch. So we'll have to develop a way to monitor that. And then at some point, you know, implement a maintenance program, if it's feasible, a maintenance program. In Europe, I will say that they're more conservative as far as regular dosing. What I mean by that is, for example, one of the top researchers for MDMA for PTSD believes that you should only do MDMA once every 6 months, one time. That's all you need. Anything more than that is too much or unethical. But then you talk to other professionals and they say, no, you can do it every 4 weeks for a few sessions. There's a lot of different opinions that they're doing research on that, which I think is huge, because that's going to impact the affordability of something, right?
Right.
So yes, that kind of, if that gives you an idea, that's just right now, that's the vision that we see. But I think regulations, laws, descheduling, what the parameters are going to look like, what the cost is going to look like, the affordability is going to really dictate what that's going to look like, I think, as well.
Mm-hmm. Let's switch gears and kind of wrap this up with a more speculative line of questioning. So, you know, human beings have co-evolved with psychedelics in many ways. And in terms of, like, you know, there's numerous other modalities that psychedelics are used for. What is your, you know, I foresee, and I could be wrong, you know, and at some point in the future, maybe in 10 years, you know, we'll be having a, you know, conversation about, you know, what psychedelics use looks like in recreational settings. Do you have any thoughts on that?
What do you mean by recreational settings? Like,
you know, I know, you know, like, let's say you go to a music festival, right? You know,
right.
If you go to any music festival today, there's a pretty good bet that someone out there is using MDMA or some kind of psychedelic, you know, drug as a in a recreational capacity. You know, do you have any thoughts on, you know, what it would take to, you know, do that safely in those settings, you know, speculatively in the future?
Sure. Well, I mean, human beings throughout history, we pretty much do the same thing over and over. And so, you know, I don't expect anything less, in a sense. First of all, as I've learned more about this field and the potential psychedelics, I've learned that every single day in the United States, there are hundreds of thousands of people that are safely dosing on their own. They're growing their own mushrooms. Some people have very specific medical issues that have really learned a lot. And so I think that more people are using it than people realize. And I think more people are very familiar with how to use it than people realize. And so it's kind of like anything else. I mean, fentanyl originally, they were taking that stuff out of the cancer patches that they would get from the hospitals. It's like anything else. I mean, I get opiates before I go into surgery, and that can feel good for a minute before they put me under. But there's people that want to take that out in the street and use it recreationally. So I don't see any difference. Adverse effects, I would say that psychedelics are going to have a lot less adverse effects than alcohol and other types of drugs like methamphetamine and cocaine and other things like that. Yeah, that's another discussion and I will say that alcohol, I think, is the most destructive thing that we have around, which is widely accepted in our society. So I actually do believe that there's going to be a much more broad acceptance over time for psychedelics in general as a whole. I really do. And I don't see any red flags or any dangers. I don't think you want to be taking 300 microdoses and driving a car,
Yeah.
That's going to be something. But I think most people don't want to drive a car. That's probably the last thing they want to do. So I think it's already widely out there. And if that makes any sense.
So where I'm kind of like heading to this is that next month, so there have been 7 or 8 like nonprofits that have formed, that have kind of gotten stood up around the state. And the newly formed Psychedelic Society of Kansas City is bringing in William Leonard Pickard.
Okay.
And William is kind of this like mad scientist type of guy. I mean, I say that in the best possible way.
Yeah.
But he was like a Harvard guy, a chemist by profession. And in the early 90s, he actually predicted the emergence of the fentanyl epidemic, because he was like looking at the ways in which drug addiction was evolving due to prohibition, right? And he accurately predicted that carfentanil, and other like extremely high potent opiate analogs would emerge. And then, a few years after that, he actually got arrested for the largest LSD manufacturing operation in the United States history. And he got a life sentence. And then when he was in prison, he wrote a book called The Rose of Paracelsus, which is, kind of a niche, kind of a cult favorite in psychedelic literary circles. But he ended up being released in 2020 under the compassionate release provision of the First Step Act, and I think he is finally off probation. His sentence was fully commuted, I think, last year. So the Psychedelic Society of Kansas City is bringing him up to Kansas City on Sunday the 23rd, and would love to invite you. The Psychedelic Society of Kansas City was founded by Dr. Christine Zemer, who's a professor at Missouri Western State University up in St. Joe, and Dale Morgan, who's I think he's a former EMT here in Kansas City. And Dale is part of a group called Rave Safe, and what they do is they go around and they have like harm reduction services at nightclubs and festivals, and they'll hand out Narcan and fentanyl test strips and so forth, in an effort to ensure that people aren't using something that's going to potentially kill them. But it's kind of a cool, I think it'll be a cool event. William is widely reputed as a visionary, And he's definitely on the list of people I was hoping to see before they are no longer on this earth. He's kind of an old guy now. And then in St. Louis, we've got a friend of ours, Seth Ferranti, who did 21 years in federal prison for LSD distribution, and came out and became a documentary filmmaker. And his Psychedelic Revolution is now on Amazon. I think he has it's a 3-part series, and the first part is covers like the history of Albert Hoffman and the emergence of LSD, and it used to be I think maybe a prescription drug in the early 60s, before Nixon came around.
Yeah.
But no.
Another thing I was thinking about, Eapen, real quick is, there's a dire need in law enforcement for PTSD relief. I mean, it is really getting out of control. And one of the reasons I bring that up is because the nature of the calls that officers have to go on a daily basis, even domestics, are much more highly reactive than they were 20, 30, 40 years ago, or at least the frequency. I'm definitely going to stand by that increase. And there's, again, the standard counseling and other types of things just aren't getting them back as quickly as possible. What would be cool to see in the state of Missouri is a pilot program with psychedelics to treat first responders that their departments can actually pay for directly if it was approved. That way that we'd be able to afford to do it. That would be, but I think the highest need right now is MDMA for PTSD, for addiction treatment, and also for law enforcement and vets. Because there's
I 100% agree. Alina from Columbia, she's a firefighter up in Boone County, is a big advocate for that. We have, had several folks in law enforcement who join us in our events, and it is a dire need in the law enforcement first responder community to have these kind of therapeutic options available. So thank you, Juan. We've got to wrap up.
Thanks, Eapen. I appreciate it. It's been an honor.
And hopefully you'll be hearing more. We'll be hearing more from you later on this year with a couple of things that we've got working.
Yeah, appreciate it. Thank you.